PBMs are robbing you day in and day out, making you work for below-cost reimbursements. Billion-dollar corporations hurting hard-working independent pharmacy owners as they line their pockets and put so many of you out of business. And now it's happening with so many pharmacy software vendors that have sold out to billion-dollar hedge funds. Are you truly happy with your pharmacy software vendor? Is support what it used to be, or you find yourself waiting on hold? Are your issues resolved in a timely fashion? When is the last time you took a look at the bill from your pharmacy software vendor? Perhaps it's time for a change. Visit our website at www.datascanpharmacy.com and give us a call at 1-877-222-7979.
It's the podcast that shakes and stirs up pharmacy. Welcome to PBM on the Rocks.
Everyone, we are joined by AALP's Emma Freer, doing some of the best reporting and analysis in healthcare right now. Welcome, Emma. We're so happy to have you here.
Yay! Thank you so much for having me. This is my first podcast. I'm really excited.
Is it your first one?
Mm-hmm.
Oh, well, I'm glad you're here. You were a blast when I got to meet you at the NCPA convention. I love your work. I love everything you're doing. Tonight's theme, well, this whole month's theme for PUTT is life after Lina Khan. What do we do without our queen? Like, how is this going to be going forward? It was looking really good there for a while. Ferguson's been surprising for me. I wasn't overly pleased with his pick, and then I mean, the tone he's taken, the stances he's taken, seems like it might work. And then we've had the entire mess with Betoya and Slaughter where Trump tried to fire him. And, where are we going to go from here? Because it seemed like we might actually have a lot of residual goodness, we'll call it, from the rule of Queen Khan. And Emma, I want to get your take on it because, I mean, you're smarter than I am.
Well, you're definitely more steeped in pharmacy and all these topics, but I do think we're seeing I don't think we can put the Lina effect back in the can. I think even you mentioned with Ferguson, like, it's not great that he defended the attempted firings of his colleagues, but we have seen him come out in support of the merger guidelines. We've seen him uphold the new merger requirement, like the stricter merger requirements. I don't think the solution to the firings is him unrecusing himself from the PBM case, but I'm glad that case is moving forward because I know that was a big concern. So I think we are seeing this weird, like, post-Lina moment where it's not totally backtracking. And I think that's because there's, support on both sides. There's this weird, odd bedfellows coalition of people who are really following her closely. And I think all the good advocacy by independent pharmacists and PUTT and other organizations to make this case happen, like, you can't turn that off, and people are really following it closely. So I hope that we see, a lot more development than what we've seen so far.
Now, and with a lot of things, and the FTC's, no different than, any other arm of the government that has a public face. A lot of things like what they're saying, it's political posturing. There's a lot of posturing involved, and posturing doesn't matter as much as actions. And what are you seeing, like, beyond the, we'll do this, we'll do that, or, these firings was just fine? What are we seeing as far as action?
Well, I will kind of selfishly highlight something that AALP's sister organization did last week, which is we had a roundtable with Commissioners Bedoya and Slaughter, and I think they are acting to hear from people who are impacted by PBMs, who are impacted by healthcare monopolies. We heard from pharmacists, we heard from physicians, we heard from a patient advocate, we heard from a representative from a nurses union, and I think, they're out there hearing from people who are impacted by by, these big bad PBMs and other insurance conglomerates. That's one action I would point to. I think, it's one thing to just say that you're going to uphold these things. I do, we were heartened at AELP to see the FTC sue to block the medical device coding merger. I think that was the week before, 2 weeks ago. To see that they're still taking this seriously, they're fighting back against consolidation. But yeah, we need even more action, and not from the two people who are currently, fighting for their jobs in court. They have a lot on their plate.
Yeah. What is your take on Ferguson and recusing himself? We still, what is it? 100 days for it to come back up. I think it was.
Yeah, I think it's 105 days.
105.
Yeah, I'm not a lawyer, so I don't know all the intricacies of that. But as a health policy analyst and someone who's following this case, unrecusing himself doesn't seem to be the best course of action. He should be defending his colleagues. And, just a few days before the president attempted to fire them, Ferguson was on a podcast, I believe, kind of talking about bipartisan action at the FTC, why it's important to have, discussion and dissensus and consensus. And, I would hope that everyone would defend the independence of the FTC and the agency's work. And I don't know that, what does this case look like with just one commissioner as the administrative law judge?
Yeah, I was worried about a few different things. Maybe they could claim he was conflicted, and it would be a whole thing. It would be better to have multiples. Monique, what was the question that you had?
Well, I actually do have lots of questions. And Emma, thank you so much for being with us, because this is such an exciting topic. It's not really exciting that Lina Khan isn't at the FTC anymore, but we're in a really interesting time right now, given with what's been going on just in the Trump administration in just about every single way. For once, I'm not talking about tariffs, but I am talking about just the overall sort of outlook on things like, the Health and Human Services Department. We have Dr. Oz is now confirmed to head up the, Centers for Medicare and Medicaid, and he at least at some point had a conflict of interest because he's got holdings in United Healthcare. Right? So all that going on, and then you have Andrew Ferguson, who has said that he intends to uphold the FTC's monopoly, but combating monopoly and combating antitrust. But I think he's distinctly not of the school of thought that Lina Khan is, right? So I was just reading that she is associated with something called the New Brandeis school of thought. And I'm just curious what you think we will see under Andrew Ferguson now. I mean, I personally, I'm optimistic, and I want very much to believe that the FTC is going to continue, fighting for all of us as consumers. But I'm just curious what you think realistically we can or should expect now that she's back at Columbia and he's, in charge of the whole game at this point.
Yeah, I mean, I don't have a crystal ball, but I do think it's going to take a lot of pressure from the public, from business owners, from market participants to keep these issues at the forefront and to hold these regulators accountable and the administration that's appointing them. We've talked a lot at AELP about, holding the administration accountable for what they promised on the campaign trail. They have talked, a big economic populist talk at times. They've said really contradictory things too, but I think it's on us to hold them accountable and to follow closely, which is hard to do when, you mentioned tariffs, we're just getting inundated with so much news and it's really hard to keep up to date. I think, the PBM lawsuit really got kind of lost in the shuffle with all the breaking news that we're dealing with. So making sure that, people are hearing how important it is to pharmacists and to patients and people are tracking this really closely, and just like the significance, we've already seen PBM reform not get passed by Congress despite really widespread bipartisan support. And I think it's going to be an ongoing challenge to kind of like keep pushing that and making sure that reform is meaningful and effective, and not just kind of like lip service to.
We need to have some teeth.
Yeah, we needed to really slap, and that PBMs is, of course, our main focus with a lot of things because we got to hammer down reimbursement. But we're seeing vertical integration within the wholesaler market in such a big way, and that's something you all have been highlighting lately. Is you've got the wholesalers buying up a lot of these oncology practices and pushing bills that will allow them to dispense their own drugs and keep things in house, and it reeks of a lot of the PBM mail order scams, and we're setting ourselves up for failure if we don't get out there and actively challenge this before it becomes a problem.
Yeah, definitely. I mean, I think the great work that y'all have done at PUTT and other independent pharmacists have done to highlight the problem of PBMs has teed us up to be able to look at other middlemen and other vertically integrated healthcare conglomerates that are driving prices up, are driving quality down, are driving independent providers out of business. We really see that, playing out in other sectors of the healthcare market, and definitely in the wholesaler space. I spent like a week making a map at the beginning of the year of all the big wholesalers specialty practice acquisitions that have either been completed or announced since January 2024, and it's just like covered in little markers. These wholesalers are not only buying oncology clinics, but also gastroenterology practices, ophthalmology practices, and if you know the concerns that come out of PBM pharmacy integration, you can kind of extrapolate that to what we're seeing with wholesalers and specialty physician practices, which is that they can then steer those practices to the most lucrative drugs and the distribution channels, and that raises costs, that gives patients less choice, that gives physicians less autonomy. There's all sorts of conflicts of interest there. So we are trying to, we kind of think of wholesalers and GPOs and, there's other middlemen in the healthcare space. But now that more people are aware of PBMs and the role that they play, we hope that they can kind of map that onto these other bad actors.
Yeah, and that's one thing I tell so many state organizations is if an idea is coming from the health plans, the wholesalers, the PBMs, or if you have a bill and they are actually like, oh, we're not going to oppose that, you question that bill. Question the fuck out of that bill, because there's something in there that they like and that they can either dance around, that they can play somewhere else. Like, it will not benefit you. So if you're not getting extreme pushback from them, you don't have a good bill. Just remember that, everyone out there.
Read the whole thing. Check your ands and ors.
Yes, read the definition. So many people don't read the definition section. Read the definitions.
And that's a good litmus test. Like, if you're not getting pushback from, the biggest healthcare conglomerates, we think you will.
You got to watch out.
Yeah, you better watch out.
I'm glad you brought up your map, Emma, because I was just looking at it, and it covers almost all of the country. It's amazing.
Yeah, and that's just from January of last year. Like, that doesn't even include the biggest oncology practice network acquisitions that, happened at least a few years ago. So I think it's kind of shocking, even as someone who is steeped in this every day, like, to see just how pervasive these acquisition sprees have been.
Yeah.
And the pace with which they evolve is amazing.
Mm-hmm. Yeah.
Yeah.
But once you see the playbook, it's like it's the same. The wholesalers aren't that imaginative. They're just doing what the PBMs did.
Yeah.
Exactly. Yeah. And I think if we know all the harms that come out of PBM, so it's not hard to think about, like, what are the harms of wholesalers owning practices? Why is that bad? There's legislation that's going to be marked up tomorrow having to do with wholesalers, and it's important that we all are vigilant and pay attention to this stuff, because we know, like with PBMs, that they've gotten away with motor for too long, and it's really hard to get those reforms passed.
Yeah. And with the wholesalers, they got something working against them. People understand what a wholesaler is. It took us years just to get people to even know what a PBM was. They still don't fully understand it, but they, kind of know it now. A wholesaler, they get that concept. So it's going to be harder for the wholesalers to pull this off. And I don't think they'll be successful, but
I'll say it's really fun to be stuck in the middle in between both of those giant conglomerate situations as an independent pharmacist. It's really fun. Get to play both
it's a lot of
sides.
fun.
Oh, between wholesalers and PBM.
Yeah.
There's dignity in our poverty, Andrew. Dignity.
Don't I know it? Don't I know it? Every day. Every single day.
I miss when I could make at least a little money, and everyone's just struggling to stay open. If you do more scripts, you are just going out of business faster. It's really hard. I mean, people are blowing through their retirements, blowing through their savings just to try to keep their pharmacies open, just hoping for something. And once they lose hope, they're not going to stick around. And we're at that breaking point, and we think the pharmacy closures are bad now. That's nothing compared to what's going to come unless we really give them something, either some relief immediately or at least give them something to try to stay open for.
Yeah, I think that's what we have had recently. Oh, I'm sorry. Go ahead.
Oh, can I ask you guys a question?
Uh-huh.
Yeah. So we're looking at wholesalers. We're also looking at, insurance companies buying up physician practices. And we talk a lot about how, independent pharmacies have really, you guys are at the forefront. You've organized, you've pushed back on a lot of bad legislation. You've really become a voice in helping educate the public about PBMs. For other healthcare workers, physicians, nurses, what advice do you have for them as they try to build up their coalitions and fight back against these same forces? Because I think independent pharmacists have really been the leaders in that. And, as we try to build out our coalition of partners, I'm curious what has been the most helpful for y'all.
Yeah. I'm going to let Monique go first, but I've got a story doing this. Monique has been doing this for years. She is the foremost cat herder in the world, between herding not only just independent pharmacists everywhere, but also the PUTT board, which is their own unique set of cats to herd. I'm going to let her take that first one, and then I've got a follow-up story.
Oh, that's sweet, Jeremy. Yeah, as you were just saying that, I was thinking, I don't know if anybody saw Saturday Night Live this weekend, but there was this skit they did this dating game setup, and Jack Black showed up as a fake Indiana Jones, and the answer to everything was, "Have you seen my whip?" So my answer to that would be "Have you seen my whip?" But if I wasn't promoting the whip, then what I would say is it starts with everybody has to be willing to be in communication with each other. Early on, one of the disadvantages that pharmacies had was that they'd been really trained in this idea that they weren't allowed to talk to each other. So the first thing is, getting people together to talk, comparing evidence, has this been happening, to you, this is happening to me. And I realize that some people listening will be like, oh my God, they're not supposed to talk about that, but they are. And then depending on you kind of have to reach a point where you can't anymore. It's like saying all abuse victims can't talk to each other. You can't compare notes on what's the level of abuse you're getting versus what's the level of abuse someone else is getting. And I think that was very smart on the PBM's part to be able to enforce that to the point that pharmacies became afraid to talk to each other. I also think that at some point you have to be willing to have that conversation with whoever you have to have it with. So pharmacists tend to be really nice people, very proper people. I mean, Jeremy's kind of they've always been
there's outliers.
They've always been the nice people who are afraid to rock the boat, right? And so you have to be willing to pick up the phone and call your your local legislator. You have to be willing to talk to your patients. You have to put yourself at risk doing that. And so I've always seen nurses as probably the bravest in our healthcare system. And maybe that's because of years of taking care of patients. Patients are not necessarily nice or sweet when they're sick. And so you've seen like nurses have to kind of toughen up. And I think they've been really good at it. But I haven't seen other healthcare practitioners.
They've got a giant, powerful union.
Nurses do. Yeah, I'm not surprised by that. And then from there, it's just like, it's information sharing. It's best practices sharing. So at PUTT, we've developed over the years, but it's always been, it started with the willingness to talk to each other. Now we have these channels. We have Google groups for our states. We have WhatsApp groups by topic. So, if someone's listening to this and they're like, I want to be part of that conversation. Well, tell us the conversation you want to be part of. We've got something called the PBM Reform, where anyone who has anything to do with the practice of being in pharmacy can be part of that. Yeah, Andrew's pointing to the PUTT Action Network, and he is the chair of the PUTT Action Network along with another board member, Kendra Kortauer. But get involved, just start talking, talk to your fellow practitioners, and then, together as a group, you can talk to those people with the power to do something. And I will just say one other thing, which is that for all of us, we've been learning slowly but clearly the limits of power. So we can have like the best bill and someone you don't expect. Last year it was Elon Musk, but this year it could be anybody else. They come in and they can tank it in the simplest way. So earlier we were kind of laughing about like, read that bill. If they really, aren't protesting it, read that bill. But I would say it's even more than that. It's like really know your community, because you never know who it's going to be. In Arizona, the National Federation of Independent Businesses is not for PBM reform, and they're the only NFIB chapter in the country that is not for PBM reform, even though NFIB itself has come out very publicly and said, we need PBM reform. This is hurting our independent pharmacies. Here in Arizona, it's like that never happened. And that's what I mean by you got to really know who's in the community. Right now, we just tried to run a fair reimbursement bill. Our bill got harangued by typical politics. That same bill is running in Texas right now. Seems like it's doing okay, but it's politics, right? So you never know if it's going to be like the chamber. Sometimes the chambers are pro-business, which you'd think they'd be pro-business all the time because they're the chamber of commerce, right? Commerce and business. But most of them are in the business of selling insurance, so they're not really going to be in our corner. But you never know. Sometimes a smaller chamber pops up and they're great. Sometimes the NFIB is fabulous. Sometimes it's not. You just don't know. So if you're going to put them on blast, Jeremy, I would say the time is coming here in Arizona.
You know me. I like to be quiet. I don't like a lot of attention.
Don't be scared.
But I will tell you, Emma, like we seem like, pharmacy's super organized. Pharmacy's doing this is taking a lot of work. We were known for being fractured. We were known for not being able to come up with a message. We still are a lot of times. We have to have a clear message. We have to have everyone behind that message, and we've got to push it. And what we're finding is in a lot of states, we go in and we try to help, and you will have warring factions within the state, and you've got to bring them all to the table and get them all pushing the same message where they're not confusing politicians or pushing competing bills or doing something like that. Because on the state level, it's like you've got to do that because they're going to get really, really confused. A little different nationally. Like on a national level, you can push multiple bills and you can do this kind of thing. On a state level, if you're doing that, it is going to really gum up the works because you have to be consolidated behind a single message. And that's one thing that we've been working on with multiple states. We did it here in Virginia, was getting everyone on board, making sure that everyone, all the lobbyists, have the same message. We're all pushing the same thing. And whenever the opposition tries to derail us, like in Virginia, they tried to push out a $4 dispensing fee to try to make all the pharmacies happy. And a lot of pharmacists were just like, looking at all their Medicaid claims and being like, just stacking $4 on them and being like, oh man, this would be a great help. And we had to explain to them, you're never going to see that $4. Look at what happened in every other state that rolled out any kind of like additional expense instead of tying it to the survey. Number one, $4 isn't enough. They can take all of that out of your dispensing fees. Number two, if they tie it to a dollar amount, that is going to screw you in such a big way in the future. It's really hard to get that raised. And we had to explain that to a lot of pharmacists here in Virginia. And it was a tough sell because so many of them were just looking like, well, that's $4 extra every prescription. No, it's not. It's going to come out of the back end. You're not going to see any of that money. And whenever they blow through the $1.7 million that they set aside for this enhanced dispensing fee, they're going to blame us for the additional cost. It's not going to help us in any way at all. So it's tough to do. It's been a lot of work. We've worked for years to try to get people talking, try to get them going. And one of the biggest things was, I think the ESI protest was really big for getting pharmacists talking and getting people cooperating and realizing you can get them out, you can get in their face. And I think that pharmacists fight back. I think that gave people something to believe in. And I think those are the two biggest things here in the last couple of years that have really given pharmacies something to fight for. And I think that's made all the difference. But it was not like this always. It's taken a lot of work to get it this way because we've just been so fractured for so long. And Andrew, kind of interesting. Yeah, Andrew's doing a great job in Minnesota. We pulled a lot of the Minnesota data as far as what their Medicaid's doing, compared their drug costs, compared their admin fees, and broke it down. And Andrew went up with that white paper, and well, he made some noise.
Yeah, no, we're getting places in Minnesota with it, which is it's been fun too, and people are paying attention to it. So it's kind of it's getting the confidence to go out and do it. Two, I think there's a lot of people that, or at least in the pharmacy world, it's like everybody had the same idea, but not talking to each other almost, and being able to bring those people together and share those ideas on how to get things accomplished has been super rewarding, at least for us in pharmacy. And I think there was an element of, everybody's backs against the wall too, that really motivated some people. So we had kind of this, we have to do something, and a message of here's what we can do. Let's get together and do it. And I think that's where other health professionals kind of need to get at as well. Finding the people that you can relate with and getting your message out there very clear, very concise, and getting everybody on the same page. And there's no reason that other professions can't do it.
Yeah, I was actually earlier on a podcast with a direct primary care doctor, and he was talking about how they need to get out and have a unified voice with physicians. Marion Mass, a good friend of ours, she talks about this all the time. Real Doc Speaks. I like Doc a lot. He talks about how physicians, we need to be as organized and as effective as independent pharmacy, and that's great to hear. You all still have a chance to stop it before it gets too bad. You've got to take that chance. You've got to swing out. You've got to come forward, and you've got to do this, and do it with us. We will help you. We'll help you get organized. We'll help you do this, because there is, to borrow a corpo term, there's a lot of synergy between us, and they want us all competing and warring against each other. They want physicians and pharmacists to be at odds, because it keeps the status quo. If we all unite and we push together, they can't do anything. We're the actual people who do things. They're financial instruments. They're nothing. They don't fucking matter in the end. If we get together and we push, they can't stop it. So it's time that happened.
I do think we have one thing that makes it a little easier for people to get their heads around, and that's that we have medications that have costs, right? So people can understand medications, and they understand when they go to the pharmacy counter, what is a medicine supposed to cost, or what is an outrageous cost. They don't always understand the drug pricing. Nobody truly understands the drug pricing. But I think that does differentiate pharmacy a little bit from, say, like oncology doctors who have medication as part of their, practice of medicine and what they do. But if that is separated from them and they are trying to, explain to somebody what the cost of delivering their service is, I do think there's a little bit of a disadvantage there. There's a big bill running in Arkansas right now. And the gist of the bill is that it would disallow PBM-owned pharmacies from being licensed to operate in the state of Arkansas. So basically, in Arkansas, you get to have a choice. You could either be a PBM or you could be a PBM-owned pharmacy, but you don't get to do both. So you get to choose if you're the PBM. And that's a very, very, very big deal. Arkansas has 735 independent pharmacies. And at the crux of this issue is that even with all the great things the state of Arkansas has been able to do, they've really led in PBM reform. They have something like $5 billion in specialty drugs that are filled by 3 PBM-owned specialty pharmacies. And we know who they are. They're the big 3, right? So it's $5 billion that goes out of state. And that's one of those things where, like, when you start to argue, like, well, is this restraint of trade, or how much is the pharmacist service worth? You can fall back on $5 billion in drugs consolidated among 3 pharmacy providers versus, the rest of the state, right? And how people are being impacted by that. So,
and I guarantee those $5 billion in drugs, the actual cost of them is probably more around $500 million.
Yeah. Well, and it was Arkansas. Jeremy, you remember in the really early days, we used to put out these graphics that the Arkansas Pharmacists Association put out themselves, and then we redistributed them, and it showed how a drug that was typically like often less than $100 was being charged thousands of dollars more. And it's so enraging. It's really easy to get people's, hackles up on stuff like that. So I would say if anyone's looking at organizing and they've got evidence like that, use it, because the public responds to that.
If you've got evidence like that, please bring it to us.
Yeah,
we like it.
We'll find an outlet for it.
We'll put it to work, trust me. Oh, and there's going to be a few things coming out in the next few months, everyone. Stay tuned.
I
never sleep.
I was going to say, it's kind of like the Break Up Big Medicine campaign you guys have, right?
Yeah.
So I listened to the was it a webinar when y'all announced that, and that was amazing. There were so many good people who came together to put that together, and it echoes exactly what Arkansas is trying to do, but on almost a grander scale. Like, I don't know if you want to talk about that a little bit.
Yes, no, thank you for teeing that up. I would love to talk about our Break Up Big Medicine initiative. But yeah, we just launched this in February, and the goal of the initiative is one, to kind of identify the conflicts of interest that come from these healthcare conglomerates, whether it's insurer and physician practice consolidation, insurer PBMs and pharmacies, wholesalers and physician practices, like all of those, spark the same conflicts of interest. They drive up prices, they drive down quality, they drive independent providers out of business. And then also urging policymakers at the state level and the federal level to pass the type of legislation that Arkansas is considering. So not only, obviously it's important to prevent insurers and PBMs from owning pharmacies, but it's also important to prevent insurers from owning physician practices, wholesalers from owning physician practices, and, really drawing, I think, from the success of independent pharmacists in highlighting the need for PBM reform and showing how we need similar solutions across the healthcare industry. And it's really helpful to hear like what's been helpful for you guys to help build up that momentum and that solidarity among pharmacists, because I think we're hearing more and more from physicians who want a place for that. We're hearing from other healthcare workers. We're hearing from patients. And the other thing that's so, galvanizing, I think, is that PBMs are not only gouging independent pharmacies, but they're also gouging patients, and both things are true. And I think when you have that kind of synergy, to use your word, Jeremy, a like corporate bullshit term. But when you have those aligned, that's another corporate bullshit term. When you have solidarity between healthcare workers and patients, we all are suffering under the system. So that's really, really inspiring. So Break Up Big Medicine, that's the website, breakupbigmedicine.com. Everyone is welcome, unless you're a big medicine.
Yeah, your
don't come.
Announcement was awesome. Your roundtable the other day was awesome. PUTT President Deb was on there. You all have been doing such a good job, and like you and Ben and Matt and everyone at ALP, like I admire everything you're doing. I'm a huge supporter, and it's been wonderful watching everything that's been coming out, because you all are leading the way with the anti-monopoly movement, and it's something that we're behind, and I mean, we support, and I'm a big fan. We'll just say that. It takes a lot to get my admiration, and you all have it.
It was a mutual fan club.
You definitely have some big brains over there, and it kudos to all of you. I learn a lot from reading your content.
Yeah, it's really good. And I just got to ask, is Matt as snarky with coworkers as he is with everyone else?
I mean, you've had Matt on the podcast. I've listened to that episode. Matt is Matt. I think it's good. It's like, it keeps you on your toes, and he's really smart. So it's good to be kind of invited to defend your assumptions and to get pointed questions, and also to learn from him. I feel really lucky to be like with all the big brains at ALP, and also to be connected to this network of independent pharmacists and other clinicians that we have, because my background as a reporter, like I just want to talk to people all day long, and I get to do that and like learn from people who are like really in the thick of things, like what's going on, and that's like a great place to be.
Yeah. Matt, I love the way he presents everything. One of my favorite things was whenever I tagged him in something and he came in and he was just like, I don't give a fuck about any of this. What you're saying is bullshit. And he was just like, no, it don't matter. Like, they're charlatans. Why even try to like argue with them in good faith? There's no point. And he had a point. I learned something from Matt every single day because of what he does. Like, I admire that. It speaks to me. I don't know if you can tell. I like confrontation. I'm a simple man.
You're a pacifist at heart. Yeah.
I'm a pacifist at heart. Yes. That's what everyone says about me.
He does not believe in violence.
Yes.
Yeah.
So Emma, what is next? Like, what's a big project coming up, or is there anything you can talk about, because you all do like to surprise people?
Yeah, well, things move fast at AALP, so who knows what's going to be on the agenda in a month. But one thing we're following really closely is there is a bill in the House that was reintroduced that has to do with wholesalers. It's called the Seniors Access to Critical Medications Act. We are really trying to educate members and the public about why this bill is so concerning. And it really, it's being presented as kind of a patient convenience bill, but in fact would benefit these big wholesalers. And I think people don't always understand that, like the big three PBMs, the three largest wholesalers control 98% of their market. They all rank in the Fortune 15 companies, which I think people might not know, but the three largest wholesalers are all there. And so we're following that really closely. We're also planning a series of roundtable events for Break Up Big Medicine. We really want to continue from the launch event, continue from the FTC roundtable, like give people a venue to share what they're dealing with in the market, give physicians and pharmacists and patient advocates space to share what they're dealing with. Because I think, like you all said, like so many people are dealing with this, and it's sometimes just a matter of bringing people together to talk about it. So that's what's coming up up next. And then I think we're also thinking about, on the one side, we want to break up big medicine. It's bad. We need to get rid of it. But we're also thinking about what do we build up in its place? What does a functional healthcare marketplace look like? And I think, the Pharmacists Fight Back Act is a great example of how do you create a more functional, humane, sustainable pharmacy reimbursement system. It's not enough to just break things up. We have to also create, something that people can feel good about and that, is worthy of patients and healthcare workers. So thinking about that, if y'all have any ideas, please, you know how to reach me.
I got lots of ideas.
There's ideas. There's ideas all over the place. Yeah. We're not just about burning things down.
No, go ahead, Monique.
I was going to say, I saw in the Wall Street Journal today that the Trump administration has approved a 5% bump up for Medicare Advantage plans. They're going to be paying them 5% more. And the rationale for this is that it's medical expenses, which I find hard to believe that it's really for medical expenses. The same article points to this investigation that the Wall Street Journal did into fake billing, where they upcoding. Yeah, additional services. So, I think about that, and I think about how the Trump administration also took the weight loss drugs out of the year 2 negotiations list, right? So you've got pharma and you've got the insurers, and they've both gotten something that they want out of the Trump administration. It's a win for both of those groups. And as I think about that, it is sort of like, well, when are the patients going to get the win, and what does that win look like? Because you're right, it's so easy to just complain and talk about things we have to tear down, but what are we going to put in place? How do we get affordable weight loss medications into the hands of the people that we need them, and how do we do it in a way that doesn't bankrupt pharmacies, but also doesn't make wholesalers and insurers so wealthy that they continue to stay in that top 10? It's a good question. We have lots of answers, but I don't think we have nothing proven yet.
But that's a good example. The Medicare Advantage, pay increases. Medicare Advantage costs something like 20% more than traditional Medicare. They're saying that they need more money because they are jacking up the prices, and all that money is going to these Medicare Advantage plans, and they are, turning around. They're denying care at much higher rates than traditional Medicare, certainly, and it's really rewarding the worst, greediest behavior. And yeah, like you said, it's benefiting big pharma, it's benefiting the biggest health insurers. Patients are certainly not, I tell every, older adult in my life, please do not enroll in a Medicare Advantage plan, because, there isn't as much, maybe awareness around that. But yeah, that's really shocking. And, if we could
it's capitation gaming. I mean, they're vertically integrated companies. They're gaming capitation, and they're just like, oh man, we need more money because all of these expenses. You're the same company charging these expenses.
Yeah, you're the expense.
Yeah, it's capitation gaming. That's all it is.
And the Medicare Advantage plans are not a great value. If you look so some of us at PUTT have been really involved in looking at these plans for various reasons, and you'll see that plan to plan, there's very little difference. United Health, Humana, Aetna, they'll offer the same basic stuff because they have to. By law, they're required to cover certain things. And then the add-on services that they provide that regular Medicare doesn't provide aren't good. I have parents that are on Medicare Advantage plans, and this is where you find out that vision that they sell you, because Medicare doesn't. They're not under any obligation to make sure that you can see, that you can hear, that you can chew your food. That's all stuff that the Medicare Advantage plans add on, but they do it in the cheapest possible way. So it's to me, reading this article and seeing this extra 5 point whatever it was percent, that it's going to be going up. I'm well, I don't know where that's going to, but I'll tell you where it's not going to. It's not going to vision, dental, hearing. It's not going to that free gym membership or those over-the-counter cards where you can shop $30 a month at your whatever store carries that OTC card. It's
Monique,
all these things that they put in.
It's competition. It's so competitive, Monique, even though it's all the exact same. Oh wait, no, it's collusion.
It's
That's right.
collusion, right?
Collusion.
Yeah, right.
Now, you know what's so great is the last 2 years, the health economists have kind of shut the fuck up a little bit about some of this.
Some of them.
Because, well, all the gaslighting over the years.
Yeah, you can only be wrong so much. I also think,
Yeah.
the public is smart. People look at the healthcare system and they don't think this is working. And I think we have to give people credit for recognizing, like, this is a broken system. People are really aware of that. And they don't want to hear an economist saying, like, no, this is really working. This is, intelligent design or whatever, which it's not.
And what we would get is the economists going, oh, no, you don't understand the complexity of the healthcare system. I live this every day. No, we would get, you don't understand. You don't get it, little pharmacist. They don't do that anymore.
I don't think it's a good time to be an academic or to be an intellectual in this country and be pontificating on what the public thinks or doesn't think. I've been, again, not to go too off topic, but if you listen to this, like, which I do, like this nonstop coverage of the tariffs and the economy and what's happening, listening to, all these different points of view. And it keeps coming down to, even they keep saying, it just comes down to, like, Americans are like, I don't care what you say, man, prices are not going down. And we know when we go to the pharmacy to get our medication.
Mm-hmm.
I mean, I've got a very basic medication. I get my healthcare through the health exchange, and I've got a very basic generic medication that isn't covered on any of the plans for no real reason. It's not some miracle drug. It's just a basic, levothyroxine, but it's like, I can't get it on any formulary anywhere. And then some years it's something else. And after a while, it's like, this is so messed up. I haven't changed. Why are you changing? And we all feel that way. I'm one of, 300 million adults in this country who has health insurance and, probably takes a medication that's fairly normal. And, sometimes it's covered and sometimes it's not. And it's just exhausting.
But no, we've got to get to the point where and not even just in healthcare, which healthcare is a priority, we've got to get to the point where we are not an economy of middlemen providing useless services. We have so many, and we justified it as just like, oh, but think of the jobs that'll be lost if you eliminate this useless service that is driving up the price for everybody. Okay, we still need to be an economy based on real things. But we're coming to the end of our drinks, everyone. We love all of you. We love your support. We love all of you as listeners, unless you're from the PBMs and you're listening to this, which I know you do. Then go fuck yourself. But we love all the rest of the listeners. And Emma, thank you so much for coming on.
To learn more about Pharmacists United for Truth and Transparency and how you can help fight PBM abuse of our healthcare system, visit our website at truthrx.org.